let me begin by welcoming everyone who's participating in the call, whether with a speaking role or not, and welcome to members of the general public who can watch this recorded public board meeting of the London North West board. I'd also like to particularly welcome Yvonne Coghill, who we're going to be calling upon to talk to you shortly, but we're very thrilled to have her here. I was fortunate to listen to Yvonne presenting to the London Chair very well indeed, so here she is again, and I look forward very much to hearing what she has to say. I'm sure we all do. So welcome to everyone. Now let me move on to the declarations of interest. Anybody with any interest to declare?
Chair, let people know that Claire Gore has a new interest, which is a trustee of the Lilly Foundation. I don't think it is material to this meeting, but nonetheless, it's a newly declared interest.
Thank you very much. Thank you. Can I then go on and ask for approval, the board's approval of the minutes of the meeting held on 27th May 2020? Does anybody have any issues with those minutes or any corrections they'd like to? Silence. So I assume that that's fine, and I've certainly looked at them and thought they were absolutely fine. So we will officially adopt those minutes. Thank you. Now, can we just turn to any review of the action points? David, can you just give us a quick commentary on any action points outstanding?
There are just 3 outstanding, Chair, and I think the exec directors will be able to cover those off very quickly and briefly if they're invited to do so.
Well, let's just invite them to do so in that case.
So 41 is around the trust objectives. We now formally issued and signed off the revised set of objectives that were reflected in the management framework that Chris put out, and they're being distributed internally within the trust this week. So that's item 41, so I think that can be closed. Item 48, around the COVID-19 risk register. To be fair, I had overlooked that, but I have now made requested that we do add a legal risk, the risk of litigation relating to other risks relating to COVID on the risk register. I have sent that through, so that will be added on now.
Well, thank you very much. So that's the end of those outstanding points. Thank you very much indeed. Let me go on to the...
Chair, does Lisa wish to comment on hers, and likewise Ellis on his?
Okay.
Shall I start, Chair? It's Ellis Pullinger. So item action log 46, with regards to the trust recovery plan. This was discussed at some length at the finance and performance subcommittee of the board, and a section of that discussion is in the performance report later. So with permission, after that item we'll look to close if agreed at the board later on.
Yes, and item 47, the second wave has been added to the COVID risk register and is on as risk 1148.
Thank you very much. With that, I will go to my report, and just a few remarks to be made. It's very clear. I attended a meeting of London chairs yesterday, and it was very clear from that the number one priority now for London is recovery. Not to say that preparation for COVID and all the other things aren't very important, but it's front of mind. I'll be saying more about that as we go through the board meeting, but it's very clear that that is a big issue across London and in the minds of those who are driving London's overall direction. So it's worth saying that to you. And I know that's exactly the same view in the trust, but it's just worth mentioning that while we're planning ahead and we're thinking ahead to how we deal with it, if there is a a second surge or any local spiking of COVID. We're planning on that. We're planning on flu. We're planning the interaction with flu. All of these things, thinking ahead, which is excellent, but also thinking about the very urgent task of getting ahead with getting a full range of services provided, and the concern that when you look across London at the waiting list numbers, it really, the need we have to address those is very pressing. We all understand that. So I think that's probably the main thing for me to say. Only to say as well that it's, having said that, it's very nice to see the staff and the exec team not looking. I'm sure you're working very hard, not looking quite as much as if you've been, exhausted and really wrung out in the way that you were quite recently. And I was very admiring of the effort you all put in, and I know my fellow non-execs are as well. So with that, let me pass over to the Chief Executive for his report.
Thank you, Chairman. I'm going to take the report as read, but I do want to highlight some things that I've said in my report. Also, of course, the board will be aware of many through the weekly non-executive briefings and board committees that have taken place during this period. But as the Chairman said, of course, recovery, which I cover in my report, is a key task now. But as we return to business as usual, I think we need to be very clear that there are still potential risks associated with COVID-19, and it's vital that our staff, patients and the public actually continue to follow the rules so we can protect the wider population as we recover during the coming weeks. Performance will be covered by Ellis as Chief Operating Officer, but it's worth saying that during the COVID-19 period, we have maintained essential services. We are delivering still again.
We're not getting great sound quality, Chris.
Sorry?
We're not getting great sound quality at the moment.
Oh, right.
Just.
What is that better?
That's better, thank you.
I shall hold my phone closer. That we have delivered against the 4-hour target for A&E, and our cancer waiting times continue to be prioritised. Just to remind colleagues that during the last few months, we've been using, or we, the NHS, have been using the independent sector to undertake urgent treatments. As you all know, we do that because they are COVID-safe pathways. They don't have A&E departments, for example. So the NHS has been funding for us and others to use the independent sector so patients don't have to wait longer than they need to for urgent treatment. Recovery plans, we've spent a lot of time, obviously, briefing the board on the recovery plans, and huge efforts, as you say, Chairman, have been made and continue to be made to expand and increase the number of elective and planned services that we can provide. Obviously, the additional infection control measures that have been put in place to separate planned and emergency pathways require a level of sophistication and change in the way that we've not seen before. But the changes that we have made at Ealing, Central Middlesex and Northwick Park sites have all been peer reviewed by the North West London Integrated Care System, and we're continuing to bring back more and more services to our patients. I'm pleased to say that daytime emergency services or emergency surgery rather has been reinstated in Ealing following the sign off of the infection control pathway. So I'm pleased to report that. Just want to move on a little bit to communicating with our staff. And as you said, Chairman, Yvonne Caldwell is with us today, and I'm also very pleased about that. And you'll see in my report, I cover off some of the really important issues that have emanated from the pandemic that has affected our BME communities and staff. Black Lives Matter, reinforcing the need to address inequality in our systems. You'll see that we've made a number of changes to support our BAME colleagues, and I've set those out in our report. And later we have our workforce race equality standards report from Claire about the actions that we're taking there as well. But I don't want to steal Yvonne's thunder, so I shall leave that for Yvonne to talk to us about. I have, however, continued to hold regular staff briefings and meetings, and importantly, I'm very pleased to say that our BME listening events, where we've had BME staff, over 150 staff attend those, have been very successful and indeed incredibly helpful in our journey to improve matters in that area. Strengthening clinical engagement, as you know, was one of my key priorities when I started with the Trust, and the board will know that we have now established the Trust Executive Group, the TEG, which includes our divisional directors, and this will provide the basis for decision making in the Trust going forward. I'm also very pleased to say that we have made now 3 formal appointments to divisional clinical directors posts, and I'd like to announce those today. We have appointed Dr. Nitu Sengupta to Women's and Children's as divisional clinical director, Mr. Matt Bartlett as the surgery clinical director. Omar Faz and Carolyn Vasey are doing a job share and are joint divisional directors for the St Mark's, or the new St Mark's division. You'll see in the report, and I won't go into detail, but we should be praising our ophthalmology teams. They were the first in London to reintroduce cataract surgery following lockdown, and that's covered in item 6. And our financial position obviously will be covered off by the CFO report later on this agenda. So I'm very happy to respond to any questions.
Any questions for Chris? Well, I must say I think, Chris, your initiative on communicating on people and BAME issues has been very good, and I'm very supportive of it. So worth remarking that. Any other comments from colleagues? Well, in that case, I'll move us on. I've already mentioned and welcomed Yvonne. Welcome again, Yvonne. Yvonne's going to talk to us, and I hope we both got the same subject for the talk. But she's going to talk to us about board engagement in equality and diversity. And Yvonne, you're most welcome to address us. We're looking forward to it very much.
Thank you. And thank you so much for inviting me. It's really interesting, actually, because I've left North West London. I live in Northwood, as some of you might already know, and I'm in Derbyshire at the moment. So I've left your side of the world and come to this. I'm going to be talking this morning about how you can support the agenda around race equality and the importance of doing that. And I don't think I need to rehearse with any of you the seriousness of this agenda or the fact that it is a priority for London. As the director of the Workforce Race Equality Standard in the national team in NHS England for 5 years, it first came as a surprise to me that London was the worst area for the experiences of Black and ethnic minority staff in England. And after 5 years of collecting the data, it hadn't improved at all. We have flatlined with regards to Black and ethnic minority staff and how they feel about working in our NHS. And in London, I have to say, it has not got any better. So clearly all the things that we have been doing in our NHS, and I have to tell you that there are so many initiatives that it makes even my head spin, haven't been doing anything to improve how people feel about working in the service. So I thought I'd do what I do this morning, instead of boring you with some of the things that I talk about ad nauseum with regards to the res. I talk about how you can actually help. because I think that that is the key thing that senior leaders constantly ask me, well, what can I do? What can I do? And apart from, I suppose, personally taking an interest in doing something, it's very, very difficult to understand and know what you have to do. So I'm going to see if I can work this this wretched thing, because it never works for me when I try to put a presentation up. It always does something different. Is that up? Is that showing or not? No.
Not at the moment.
No, it's not there. Oh God, it's always something awful always happens when this is a. I'll see if I can what I can do about it. And see if it will work
There
for
we
me.
are.
Yeah, got it now.
Is it working for me now? Which is wonderful. So this is your hospital and this is your res data. And you know what I picked up, which I thought was really quite fascinating, is that your organisation has one of the highest number of Black and ethnic minority staff in the whole of London. I mean, 62.2% of your staff are from backgrounds other than white. And I think that that is quite a phenomenal number, because it is one of the highest in London. But I'm not surprised, living in the area and knowing the area, that doesn't surprise me at all. What I've got here are your res indicators for 2019, and that might well have changed, because bearing in mind we collected the data over a year ago, so some of this might be different, better, some of it might not be as good. So we know that indicator 2 is shortlisting to appointment, and what that says is 1.21 times more likely for you to get a post in your organisation if you are from a white background. And actually that's not too bad. It's the whole of the NHS, what we know is that indicator 2, 3 and 4 have improved, and we have begun to close the gap on those indicators, and I'll say a little bit more about that in a minute. Indicator 3 is an interesting one, because that's the one where we look at formal disciplinary processes, and you can see that you're nearly 2.23 times more likely to go through a formal disciplinary process if you're from a Black and minority ethnic background than if you're from a white background in your organisation. And obviously that needs to be looked at, and something needs to be done about that. We have a target across the whole of the NHS to reduce that figure, and actually it's coming down nationally. But I have to say that this is one of the highest figures that we have in London. So you know, there's something that needs to be done about that. Indicator 4 is looking at whether or not people are able to go from non-mandatory training. And it's a very strange figure here, because what that says is that your Black and ethnic minority staff are much more likely to go off on non-mandatory training than your white staff, because the figure that we're looking at is 1 for 1, means that there's equity between white staff and Black and ethnic minority staff. When it comes down to 0.22, and I would put a question mark over that figure, it means that your Black and ethnic minority staff are going on non-mandatory training at a much higher rate than any of your white staff. So I don't know whether or not that's something that you'd want to look at. But the point about these 3 indicators is that they're process indicators, and that means that they're indicators that you can do something about very, very quickly. They're indicators that you can change practically overnight if you change the policies and the processes within your organizations. So, for example, if you change the way you work with disciplinary processes, for example, you can reduce that down practically overnight just by doing things in a different way. And across the country, we found that people have done that and managed to do it. But the interesting thing about this, and we didn't know this when we started doing the Workforce Race Equality Standard work, was those 3 indicators have no correlation or impact on the cultural indicators, because we made the assumption that if people were appointed fairly, if they didn't go through formal disciplinary processes, if they were sent off on a non-mandatory training, hey presto, they'd be happy, and then we would get better cultural results. Absolutely not. It has not worked like that at all. So even though we're closing the gap on our process indicators, our cultural indicators, indicator 5, 6, 7, 8 and 9, are not actually closing down. So on indicator 5, which is bullying and harassment from the members of the public, across the country, we know that you are bullied and harassed by the public in equal measure, whether you're from Black and ethnic minority backgrounds or whether you're from white backgrounds. It doesn't seem to really matter. And there's usually a sort of parity around, or give or take two points for Black and ethnic minority and white staff. So there's something about our public treating us in a better way, whether we're Black or white. We need to actually do something about, you know, zero tolerance of people not treating our staff badly. When we come to indicator 6, which is bullying and harassment from our colleagues, in your organisation, it's practically non-existent. So white staff and Black staff are saying around about the same thing. It's not too bad. I'm saying it's not too bad. 33% and 34% is not brilliant. But what I'm saying is that there isn't a massive gap between your Black and ethnic minority staff and your white staff. Indicator 7, which is about equal opportunities, is where I start to get worried, because what it says very clearly and very interestingly is that your Black and ethnic minority staff are saying in much larger numbers that they're not getting equal opportunities as much as their white colleagues. But if you remember what I said about indicator 4, you will ask, I have to ask myself, well, what's going on here? Because if you're sending people off on mandatory training at the rate that this indicator says you are, it surprises me that so few people are feeling that there are equal opportunities in your organisation. It's just something that I would really want to delve into and have a really, really good look at, because that's really, really very odd. Indicator 8 is the indicator that worries me the most across the whole of the country, because this is the one that talks about bullying and harassment from senior leaders and team leaders and staff. And we know that there's a correlation between how staff feel and their line managers. And the more people feel that their line managers are interested in them and are, care about their progression and so on, the better the indicator in the staff survey shows that they are, their EDI, equality, diversity and inclusion, is improving. So it's a really important indicator. And what this says is that, 16% of your white staff say that they feel that they are bullied and harassed, and 10.7% of your BME staff. Actually, I have to say something here. With indicator 8, it is the one that where if your white staff are saying that they're having a bad time and your BME staff are saying they're having a bad time, then we really need to do something about it. And in this organisation, I think that is something that we really need to look at. And by the way, this is round the wrong way. It should be the other way around. So it should be 16.3 BME staff and 10 for your white staff. So the person who did my slides made that mistake. So just to be clear, it's 10.7 for white staff and 16.3 for BME staff. And the final indicator is indicator 9, and you might tell me if I'm right or wrong with this, but it says that you have 2 members of the board from BME backgrounds, and that's what that indicator means. So just looking at that across the board, there are several things that I would want to look at and look into. And I think it's really important that, and I'm sure that you're doing this and you've got an action plan around it. So the question then is, what do we do about any of this? Now, I'm in the process of doing a strategy for David across the whole of London, because Sir David Sloman is very clear that we need to do something about this. And I came up with something which some of you might have seen called the 7 A's in terms of allyship. So this is it. The 7 A's of becoming an authentic ally. And this is what we need to do if we want to make a change around this agenda. The first day is probably the most important, and this is the one where people always say to me, you know what, Yvonne, we really are committed. Committed is the word that people use to me a lot. We really want to do this. We really want to make a change. And I don't think there's anybody that I've ever met that has told me that they don't want to make a change. But we all know that that's not the world that we're living in, and people always tell people what they think they want to hear. And having the appetite to do something around race equality, it takes quite a lot. And people will say what they think others want to hear. So does the board have the appetite to do this and work on this in a way that's going to make a difference? Or are we collectively saying that we have a little bit of appetite, but not very much? And the proof of the pudding is always in the eating around appetite and whether or not people are going to put the energy and effort and commitment into making the changes that they need to make. The second A is for ask. You have to actually understand what you're dealing with here, and the agenda is not easy. It is not like gender, it is not like LGBT, it is incredibly difficult and complex and tricky to understand race inequalities. So you have to read, you have to understand, you have to look at the data, you have to be able to listen to webinars and so on to understand the depth of complexity and the trickiness and the deep-rootedness of this thing called race inequality that spreads across our world. And mostly people think that they can tick the box and make this one better, and they cannot. It is incredibly hard. Having done the homework, you have to then accept that there is an issue and there is a problem. And for lots of people who are not from Black and ethnic minority backgrounds, it isn't a problem. If you read Robin DiAngelo's book on white fragility, you'll see and understand very, very clearly that the issue doesn't exist of race doesn't usually exist for white people because it is as it is and their world is as it is, and it is very, very difficult to understand what the world is like for others when you're living in a different kind of atmosphere and environment. So accepting that there is a problem is great, and it has to be done. Fourth, you have to acknowledge, that acknowledgement is external. And that's where people are expecting to hear you say, yes, there is a problem and we are going to do something about it. We're not just going to sit on our hands and wring our hands and say, oh dear, isn't it terrible? Here we have the fifth A, which is apologize. The apology is really, really important. It's about really feeling sorry that this is happening to people. And I don't think there's anybody who wouldn't say that they're sorry that Black and ethnic minority people are losing their lives in disproportionate numbers to their white colleagues. I think people are very sorry about that, and I think people acknowledge that there's an issue around this. I think most people think or believe that it's to do with comorbidities or people living in houses of multiple occupancy and people having been too obese and all the rest of it. But actually, there's more to it than that, and it's about how people live their lives and the impact of living a life that is not entirely conducive for you impacts on your physiological health and how that can mean that you're more compromised and able to pick up disease than others. So you are more likely to get diabetes, heart disease, coronary heart disease, asthma and COVID. So it is no surprise to people like me that this has happened. And then, of course, the making assumptions, and lots of us do that. We make assumptions all the time about what will work for Black and ethnic minority people. Well, let's do a bit of unconscious bias training, or let's do some reverse mentoring, or let's do this or that, and bring in people from all over the place to make a difference for our organisation. And over the 43 years that I've been in the NHS, none of it, not a jot, has made a difference. And that's because we don't come at it from an evidence base. We just bring people in and expect them to be able to solve the problem for us, when actually the problem lies with us. And we have to make the changes if we want our organisation to be different. So making the assumptions that things are going to change just because you throw a little bit of money at it and bring somebody in to do some work is not gonna work. And then finally, when you've done all of that, you then take the action. And I've put together this wheel, which I've been sharing with people across the whole of the NHS. People have taken to it quite well, actually. I'm surprised that they like it as much as they do, but they do, because I think it tells people and shows people quite clearly steps that they need to take in order to get to where they need to be. And I'm not looking to boil the ocean here. I'm just looking for each organisation to take responsibility and do their own thing within the sphere of their control. And if each organisation does that, ultimately we will get to where we need to be, because the thing that we're dealing with is so complex and so difficult. You have to focus on housing, the police, education, the judiciary, government, across the board. It's the same issue, and that's because it's not just a process issue. It's about people's attitudes, their beliefs, and their behaviours that we're dealing with here. And because of that, it means that we are going to have to really look to ourselves in order to make sure that we we can hit some of these, I don't want to call them targets, but this initiative in order to get to where we need to be. And I don't want to say too much more than that, apart from, you know, I'm around for the next month. I retire on the 4th of September. But David's asked me to come back in November to help London to implement the strategy that I'm putting together. The strategy that I'm putting together is going to be evidence-based. I'm not going to be recommending that we do anything that doesn't work. So that we have a menu, so London has a menu of interventions that have been shown to work. And some of those interventions are not, they're not easy for people to implement, because it means people really changing the way that they think and the way that they sometimes behave. And I think that that's probably all I want to say. If there are any questions, then I'm more than happy to take them if we have time. Thank you.
Thank you. Thank you. Very terrific presentation. First of all, thank you very much. And we've got a number of people whose hands up. I'm going to start with Chris.
Yeah, thank you, Yvonne. That was great. And I can remember before I started in London North West, so back in February, looking at our res data and sort of recognizing that there's clearly much to be done. And I think you know, and I do agree with you, the process elements of addressing some of those res data are the easy things. So, you know, we have very recently introduced or to ensure that on all interview panels, a BAME member of staff is present. I require personally the chair of that panel to write to me if a BAME applicant is not appointed, to understand why that might have happened. And I think that does provide us with some rich data potentially. It also makes the panel chair think before they act. We've also introduced what we call cultural ambassadors to work with those disciplinary processes to ensure that we address them up front, and that a cultural ambassador reviews those with the manager. So say there are a whole range, aren't there, as you know more than anyone, of the process things that we're doing. I think the real challenge is the cultural challenge that we all face. And certainly, you know, I'm pleased that my leadership team, and I know Amy as the board, are not in denial about the fact that we have a problem, and we have to do something about that, and that sits and will, you know, I mention it in my board report, but it is a feature of, you know, my top priorities, because when I sit and Yvonne, you came to one of the listening events, didn't you, that we had, and the fact that they're so well attended says something. And we do need to listen to our colleagues, because their experiences are without question for us. So no one can be in denial about that. And again, the other thing to mention, of course, that, and I know Amy has might, that at the time of that data, there were 2 BAME members of the board. There's only 1 at the moment. But we've also been working, or the chairman has been working with NHS England and NHS Improvement to look at the appointment of some NED associates that can come from the BAME background, that can help us and work with us and provide us with much greater diversity, which I think will enrich our decision making a great deal, particularly, as you say, with such a high proportion of our staff being BMA backgrounds. And I think the thing that one day, hopefully, you won't be seeing a white 50-year-old, 59-year-old man here, but I can remember coming to listen to you, Yvonne, at one of the chief execs at David Sloman's chief execs meeting, and actually, out of, I don't know how many, 38, 40 chief execs in their room, there was only 2 BAME people. One was you, and one was the chief executive of East London Foundation Trust. And that's got to change. And I think that if you walked into that room 20 years ago, you would have seen the same with regards to everyone would be like me. At least now we're seeing sort of a good 50-50 split of male and female chief executives. Wouldn't it be great to be able to go in you know, less than 20 years' time and see that difference that reflects the multicultural nature of the capital? So You know, I'm passionate about this because ultimately, to me, if we're appointing, for example, the wrong people, or not the best people into the jobs, there's one person that suffers at the end of that, and that's our patients. So we've got to get it right. That's enough preaching from me.
No, thank you for that. I really appreciate it. I do appreciate your support, Chris, and inviting me back and so on. It is not always as easy as that to get onto the board papers and to be able to have 5, 10, 15 minutes to talk about this agenda item. It's a challenge. But I think London is moving in the right direction. I genuinely feel that chief executives and senior leaders, I was on a call yesterday with the 5 accountable officers for our STPs and ICS, and they are all wanting to make a difference. So I think there is a wind, I can feel a wind of change, and I can feel that there is positivity, and I think we have a window of opportunity to do things a little bit differently. And it might, I don't even think it might, I think it will be uncomfortable for a lot of people to go down that road, which is why I've said to David, I'm quite happy to come back in November after I've had a break and help with some of this. I've just put into the chat box that I am a Northwest London person. I spent most of my career in Northwest London, so I'm more than happy to come back and and support you guys and help with anything that
you trained at the Central Middlesex, didn't you?
I did. I did.
Yeah.
I did. I trained at Central Middlesex, and I also did some work at Northwick Park Hospital as well. That was going back many more years than I care to remember, Chris. But yes, I did. And I live in Northwood, which is just up the road. So you're my local hospital anyway in Northwick Park. So from that perspective, it means something to me to get this right, and to help you to do that.
Thank you very much. That's great. Let me bring in. I saw Neville had his hand.
Okay. Hi, Yvonne. Thank you very much for the presentation. It was great, actually, and I agree very much with you calling out the complexity of this question. Complexity not just of experience, but the complexities of identities. This is not simple stuff. And I thought the 7 A's is great, and it helps simplify a route into it. So I think that's great. My question is this: could you identify any organisations, whether in the NHS, the public sector or not, really doesn't matter. It doesn't have to be UK either, that really got this stuff done well and quickly? Because my big concern isn't that there isn't a willingness to do this, is there just isn't an understanding of how uncomfortable it will be to do it quickly. Indeed. And doing it quickly is what matters. Do you have any views on that?
So the quickly thing is really tricky because, this the system and the world we live in has been 400 years in the making. So, unpicking that is going to be incredibly difficult. It's not a quick win. But having said that, a couple of organisations are moving things in the right direction. So, I always go on about North East London Foundation Trust because it's the only organisation in the whole of England that has moved all of the indicators, all of them across the board, in the right direction over the last 5 years. So they've closed the gap on all of the process indicators, but they've also closed the gap on all of the cultural indicators. And the interesting thing about that is that as Black and ethnic minority staff begin to feel better in the organisation, so do the white staff. So it's not as if you're leaving people behind. The data shows very clearly that the gap's closing for both and that it's going in the right direction. And the other organisation is the one in Richmond and Kingston, Richmond and Twickenham Community Health Trust, I think it's called.
Hounslow and Richmond Community Healthcare Trust.
That's the one. And they are doing incredibly well too in terms of closing most of the indicators. They haven't got a 5-year stretch like North East London Foundation Trust, but they are going in that direction. They are closing all of the gap. So it's taken them about 4 or 5 years to get to where they go. And the key thing with both organisations is leadership. I know it sounds, when I say it to people, it sounds really kind of, we've got brilliant leaders anyway, so what do you mean? But actually, it's leaders who are really going to take this seriously. And when I say seriously, do things and make decisions that are going to be uncomfortable for some people. Because the thing that we don't talk about, and we don't in the NHS, because we all assume that we're bound by the NHS constitution and we all want the best for everybody and all the rest of it. But actually, we're all human beings and we all have different thoughts, views and feelings about all sorts of things, including race. And, you know, people are constantly telling me, you know, Yvonne, you know, we really want to do this. I know some people do and some people don't. And I think the work that I'm doing now in London at the Whittington, doing a cultural deep dive into the organisation, shows very clearly which parts of the organisation have problems and which parts. And again, it comes down to leadership. So as a board, you need to know what's going on in all the parts of your organisation around this agenda. And the work that we're doing is identifying in directorates what issues are. So you see very clearly what the indicators are in your directorates as opposed to overall in your organisation. And that then means you have to take some action within those specific parts of the organisation. And that's the hard part.
Okay, great. I'm just going to call on Vineta Bala to ask a question.
Thank you, Yvonne. It's nice to see you.
Hi.
And, and it was very useful to have you hold up a mirror to us on our own REST data. Very crystal clear view. So as a BAME board member, a lot of my inputs and supports towards addressing this BAME equality agenda are based on my own lived experience, or what I learned from, listening to people like you or reading. Yeah. But you've said a very important thing, and you've said that, and exactly what bothers me is whether what we're doing is actually going to work this time, and is there clear evidence behind it? So I would really like to hear from you that what are some of the evidence-based practices, especially around equal growth opportunities and mutual respect, that we can bring in quite quickly. I know we have to wait for you till November, but before that, because we are moving ahead with our REST agenda. Yeah. So we'd be very grateful, even if you tell us, do these two things to make a real difference.
Yeah, do you know what I would do if I was you, from just from after today? I would actually look. I don't know how many directorates you have or how many divisions, because people call them divisions of directorates. But do you know what? I'd get your analysts just to break down your res data in your directorates. I think that is a really an enlightening, I have to tell you, exercise. It's really fascinating. I mean, I did this at Sheffield probably 2 years ago, and it was amazing to see that in some directorates there are very few Black and ethnic minority people being recruited. In others, there's no disciplinary processes. That it's fascinating for you to see. But what that does is it identifies people, because you know who the people are that are actually responsible for those areas in your organization. And that's why I say it's really, really difficult, because what we usually do is we work this and manage this in a collective. So we kind of think, well, it's all of our business, and we don't really drill down into what's really going on. So that's incredibly important. The other thing that I'm doing is doing the work with the middle managers, because they've been like the sticky middle that's been left to its own devices for too many years. And what we know is that if we work with that group of people, what happens is that staff begin to feel much more comfortable. They feel that they are being valued and appreciated. So then the numbers of disciplinaries go down, people leaving go down, people wanting to come and work in the organisation goes up, and we start to save money on having to pay for agency costs. That group of people, and we have the evidence to show this with the staff survey data, are a group of people that we really need to focus on in order to get our staff to start to feel better. So I would work with our middle group, and I would also look to see exactly what was going on in the organisation, so that I would know which directorates I need to focus on in order to help with this agenda. Just two very
amazing. Thank you.
Thank you very much. Let me bring Andrew Van Doorn in. Andrew.
Thank you. So just unmuting. Thank you, Yvonne. Yvonne, I've been reflecting over the last few months about the experiences in the community of COVID, and about actually for our staff, actually their experiences are not just what they have in our hospitals, it's actually what they experience in their lives.
Yeah.
Actually, the whole kind of question of race inequality in the communities is something that we have to start to think about and address if we're to address issues within our organisation. I suppose where I see organisations in the NHS working more proactively around the patient experience is probably in the mental health trusts.
Yes.
I wonder what your reflections are for an acute trust like ours about how we marry together workforce issues with patient experience issues.
Yeah, I mean, and it really matters, because when I first started down this road of doing this work, people put staff over here and patients over there, and actually they're one and the same, are they not? Our staff live out there, and our patients come in from out there. And what we know, because we've got the evidence from Michael West and Jeremy Dawson, they've done lots and lots of work on this, is that you get a better patient experience if you're Black and ethnic minority staff. And in fact, in a document they've written called High Quality Care and Management, I think it's called, it was out in 2009, it actually states very clearly that patients get a better experience, and you will know that if your Black and ethnic minority staff are valued, appreciated, and actually having a good time in your organisation. So the outcome for patients has been proven to be better as a consequence of making sure that your staff feel valued and appreciated. And actually, in North East London Foundation Trust, we can see that with the data, because as the staff have got better, the outcomes for patients have improved. I've now left that role, and the work is still ongoing to collect the data, because everything I do, I make sure, because I know the NHS really well, I have to have an evidence base, because if I don't, people will kick me out the door quickly. Well, what's the evidence for that, Yvonne? So I try to do lots of evaluation, and one of the key evaluations around all of this is that our patients have a better experience if we have a diverse workforce that is fully included. That is, that they feel that they are part of the organisation, and then that sort of it exudes from them when they are actually treating patients. And I think that that's the biggest thing that we can do. And I always said to all my comms people, we really have to make that connection and get that into people's heads, that this isn't just about Black folks, having high level positions, which would be nice, by the way, but it is about the fact that there's something about motivation, staff feeling valued and appreciated, and patient safety, satisfaction, and high quality care. And that triangle is really, really important around all of this. So hope that helps.
Well, I think there's if there are other people waiting to ask questions, I'm sorry, but I think I'm just going to leave that as being your last and very, very clear and well expressed word. And personally, I look at this and I think of the fantastic contribution that all our staff, including our BAME staff, made during the COVID crisis. And I do feel regret and I do apologise to anybody who feels that in the middle of making all those contributions that they've made, that they weren't treated properly or fairly or as they should be. So I do mind it very much personally, and I just think we need to be prepared to say that. So thank you very much indeed.
You're very welcome.
Fantastic contribution from you, and really appreciate you taking so much time with us. Thank you so much.
You're very, very welcome.
Thank you. Yeah. Now I'm going to move us on.
Thank you.
Thank you.
To the Director of Estates and Facilities, who's going to talk to us about health and safety.
Chair, thank you. As board members will see, this is a routine report on an annualised basis and covers the period for the financial year 1920, with an element of look forward to 2021. For information, this was reviewed by the Quality and Safety Committee and approved, with a request to include comments in respect to some Statman training data, which you'll find at page 15, and a reference to COVID at page 27. We don't underestimate the extent of the COVID issue from a health and safety standpoint, but that will predominantly be covered in next year's report, given it was very much at the start of that process when this report concluded and is bounded by time. I'd make two exceptional points, if I may, and then open to questions. The first thing is to note the revision of the group. We've made a clear change of direction, I feel, as an organisation in terms of the importance of health and safety, with much better engagement divisionally, with the change of the terms of reference and the attendance at that. and much greater board visibility going forward around what is a really clearly an important issue. And I think it's a hugely positive step. I'd also note on that basis we've included now environmental considerations into this agenda, which was previously absent and obviously is an increasingly important part of the role of this group, particularly in respect to London and the environmental challenges that are well known around air quality and the health impacts of that. The only other point I would note is that board members will be aware we've had historically a very poor relationship with the London Fire Service. That has continued to grow with a clear memorandum of understanding signed between the parties and a very good working relationship. And for information, the major concern remaining for them is the compliance in the RRU area, which is being addressed as we speak, with work undertaken over the summer through to the beginning of October to conclude that issue. So I very much feel that the rather challenging history from 2 or 3 years ago will now be formally put to bed with the physical inspection of those works in the autumn. And with that, Chair, I'd open up for comments or questions, please.
Any questions? And no, Neville. Neville, you're on mute, I think, at the moment.
Can you hear me now?
Yes, I can.
Yeah, sorry, just one minor point, Mark. But I couldn't help notice that on page 70, when we're talking about the young person's risk assessment percentage, it's really, really very low, much lower than the others. This may not be significant, but I wanted to check on it.
We're not hearing you, Mark.
Sorry, apologies. You have me at a disadvantage, Neville. Sorry, when you reference page 70, I'm sorry, I'm working off a PDF version. Is that within this, which page in this report?
It is 45 of the report. It's in the appendices. I just call it out because it's significantly lower than any of the others.
If you're okay, Chair, I'll take that one offline and report back
Yeah,
to.
that's
Right.
great.
Fine.
Thank you very much. Any other questions just now? Janet?
Mark, just one small suggestion, please, on page 15, where I think some sort of explanation as to why manual handling level 2 is only at 80%, given it's online, might be helpful. But thank you for taking on board the other suggestions from the committee when we discussed it the last time.
No, understood. I'll look at that. Clearly, there needs to be some coordination there with HR colleagues around the lack of compliance on stat mantra.
Okay, well, if there are no other questions, I'm going to move on, but let me make sure that I know exactly what response you're asking us for on this report. Are we noting this? Is that all?
We're noting the historical components and we're approving the forward plan for the year 2021.
Very good. So the board's happy to approve the forward plan? Yes. Okay. No, hearing nothing to the contrary, Mark, I'm going to take that as assent. Thank you very much.
Very much.
Thank you very much. And then we're on to the safeguarding report and the chief nurse, please.
Thank you, Chair. Yes, this is the annual safeguarding report. Similar to Mark's previous presentation, this was discussed at the Quality and Safety Committee recently. So, I mean, really, I just want to flag to the board the importance of safeguarding, and I hope that this report does raise that and the amount of safeguarding that goes on. It's well documented, the issues in Brent and Ealing and Harrow, the service, the population that we serve. I just wanted to pick out just a few highlights from the report and then just one issue of concern. So just some celebrations really, and we did discuss it at Quality Safety, just to flag up our FGM service for non-pregnant women, which is the first one in the country. We commissioned directly by NHS England to provide this service, us, Bristol and Birmingham. That service started in October and has proved very successful in year, providing a great service. We will be evaluating it very shortly with NHS England, but unique in the country. Just an update. We have noted quite a lot of compliance against deprivation of liberty safeguards legislation, and we have been waiting for the guidance for the law to change, and it was due to change in October 2019, and we never received the guidance. And we did actually this week receive a letter saying that the new DOLS legislation won't come into practice until April 2022. And so we've got a whole year and a half in order to work up how we respond to the new legislation with regards to that. But again, the guidance hasn't been released, so we don't know what that's going to look like. And then just finally, I just wanted to raise the issue of adult safeguarding level 3. You know, our compliance is not where it needs to be, and I wanted to explain to the board why that is the case. So we did a reassessment of all the staff who are required to undertake safeguarding level 3, probably in about January of this year, with the introduction of a new safeguarding lead, and as a result changed the amount of staff that require safeguarding level 3, which has massively increased the numbers of staff who require it, and therefore we are working through a backlog of staff who have been newly identified as requiring safeguarding training. We need to be compliant by next August, and we would hope to be so, but in the meantime we are playing catch up, and that has not been helped by COVID, as I'm sure you can imagine, and we are in the process of trying to develop an online package. The collegiate guidance says that we have to do it face to face, but that's not an option at the moment. So we are hurriedly working that through, and hope to start really addressing that in a more constructive way in the next few months. And that will be added also by the fact that we have appointed a substantive head of safeguarding, Francis, who starts in September, and this will be one of his #1 priorities when he starts. So that was all I really wanted to say. Happy to take questions.
Any questions?
You got one from Drew.
Yeah, so Chair, I thought it's not a question. It's rather I thought it would be worth mentioning, given that we're taking the annual report, that the audit committee received an internal audit on adult safeguarding at its meeting in September last year. The internal audit looked at the robustness of governance, monitoring and reporting for adult safeguarding. It resulted in a moderate assurance for design and moderate assurance for effectiveness. There were 3 medium-level recommendations, all of which have been completed.
Thank you. Thank you. Well, are there any other questions? No.
Vanessa.
I have.
All right. Go ahead, Vanessa, please.
Okay. So I was just looking at the report on page 10, Lisa, and, you know, of course, I'd seen that previously also, but, you know, every time I look at the 15-year-old case study, it just shows us the need for better linkages with mental health. And I'm wondering how we're progressing on that.
So
So I'm happy to comment, and I don't know if Ellis would like to come in because he's doing a lot of work as well on mental health. You know, we do have mental health services in our organisation every single day of the week, and the safeguarding team work with them continuously. There remain, I think, organisational boundaries and challenges for us working with our mental health partners, and I think part of that is that they have different targets to us, they have different requirements, and so, for example, and I think this is the hot potato at the moment, and I'm sure that Ellis might pick this up, that a child, you know, it's a patient waiting for 12 hours in RED. If it was for us, that would be an SI, it would be a reportable 12-hour breach, and you know, but for the mental health teams, it's not a reportable target as far as I'm aware. So when we have declared SIs on mental health 12-hour breaches, we have written our part of it and then really struggled to get them to write the second part of the DATEX. So there are really some significant issues. However, on saying that, Ellis has been doing lots of walk-arounds with the mental health teams. We're trying to streamline our pathways. I don't know, Ellis, if you wanted to comment on that.
Thank you, Lisa. So as you say, we've myself, yourself, Lisa, Simon Crawford, have been over the last few weeks engaged with a number of conversations with CNWL and the CAMHS component of that, and that did culminate in a senior director walkabout with myself in person last week to literally walk the floor from our Northwick Park ED. So we walked the floor as if a mental health patient had presented and was going over to the CNWL building, to the assessment centre. So there are challenges, and I think Lisa's laid those out. But I am pleased that we have their full attention and support, and we are actively working through how we can improve the flow across the Northwick Park site in particular, not losing sight of Ealing as well. And I'm sure we'll be able to report back progress on that in the coming weeks and months. But it is a challenge, as I've reported through both the Quality and Safety Committee and the Finance and Performance Committee. The current situation is difficult, certainly with patients having to have very long waits in ED, which obviously is a concern to us all.
Yeah, just to emphasise, there have been, I think it's 7 12-hour breaches in the last four weeks. So it was discussed again at the A&E Delivery Board yesterday. I think they recognise there's an issue. There is an issue in terms of the bed capacity to move patients to, and also what was said yesterday, although I haven't seen the evidence for it, but no reason to dispute it, is that 40% of those admissions were not known to mental health services prior to prior to their presentation to us. So they are under increased pressure themselves in terms of the number of presentations they're seeing in this post-COVID phase. Okay,
thanks very much. Janet, let me bring you in.
Thank you. Lisa, as you say, we discussed this at a sub-board committee earlier last week, and there's some really moving stories in here, and you've referred to the Hispus clinic. To what extent have you had a chance to think about how we can communicate some of these really good stories, both internally and externally?
So I mean, just to touch on the Hibiscus Clinic, that was part of a national press thing, and Tracy and I went to the national launch with Matt Hancock and the team. I have never seen a team so excited at a national launch. It was truly emotional launch. Francis starts, as I said, in September. We haven't been doing our safeguarding pamphlets or leaflets in recent times, well, just during COVID, and so that will be one of the things we need to reinstate our safeguarding newsletter. There are lots of things for us to do around that, so we will be reinstating that, but I suspect it won't be till winter time. Thank you.
Very good, thank you. Any other questions? I don't think there are. Good. Okay, well, let me move us on. Thank you very much for that. Thank you very much. And we'll move on now to Infection Prevention and Control Annual Report.
Morning, thank you, Chairman. So this is the annual report. This is part of the Health and Social Care Act, the Code of Practice, to produce a report written in the format of a national template. It will, of course, be of interest to members of the public. The report outlines the governance arrangements about infection prevention and control in our organisation. It summarises the mandatory surveillance data. There's particular reference made to the changes in definitions that were applied last year to the Clostridium difficile infection. You will see there some very different changes and how our target moved up to 68 last year from 46 the previous year. It also summarises the incidents and outbreaks per quarter and sets out some priorities for us this year when we start in our recovery post-COVID. The Quality and Safety Committee reviewed this last week, so it's here today for noting and approving as an annual report. Happy to take questions, Chairman.
Any questions? David Tabb. David, you need to turn your mute off.
Got me now?
Yeah, I can hear you now.
Fantastic. So thank you, Fiona. I know we discussed some of this at the Quality and Safety Workforce Committee last week. I was just struck by, and as we discussed, the rate of Pseudomonas blood infections. And you're going to have a think and look into this. Have you had any further thoughts?
Yes.
It's a very serious and nasty organism to have in your blood.
Yes, yeah. So David, you asked me at the meeting about mortality data, which I haven't put together yet, but I've put it in our plan for this year that we will conduct an in-depth review, just like we do for the E. coli. I think that's a really good thing to do, to take a selection of cases and do a deep dive into them. And then I will obviously include it in the quarter report. So I will be doing it within this financial year.
And the only other request, again, I know I'm boring about this, is to have some benchmarking with regard to the C. diff cases with other London trusts. I don't think it's here, is it?
No, David. So I mentioned when you raised this last week, I think that this is the annual report. So we don't tend to report on other people's data, but in the quarterly reports, I always put the benchmarking data for you because I know the board is interested in that. So it's not really part of the national template to put benchmarking. This is about our organisation. I've put at the very beginning in the summary, David, the average rate per 100,000 bed days, and that's the only bit I've really included to make comparison, but it's always in our quarterly reports is the benchmarking data.
So could you just reassure the board that 11 cases per 100,000 is pretty reasonable?
It's yes, it is, yes.
Thank you.
Very good. Any other questions on that?
So, Chairman, it's Chris here, sorry, can I just say, I know this reflects sort of 2019-2020 report, but I think we should record our thanks to Fiona for all the work that she's been doing sort of since then. You know, we've been in a pandemic, and clearly the Director of Prevention Infection Control has had a pretty tough time. So a big thank you, I think, to Fiona for everything she's been doing.
Thank you.
Yes, well done, Fiona. Very good. Well, we'll pass on noting that report and approving the forward plans. Thank you very much.
Chair, you've got Drew and Vanetta whose hands are up.
Oh, I didn't realise. I'm so sorry about that.
It's fine. It's fine.
Drew, let's start with you, and I'll come to Vanetta.
I was just going to ask about Ealing Hospital water supply. I note that that you mentioned it in the report on 12 and 13. And I also note that in this year we received a report by PHE, if my memory serves me well. Can you just provide us with some assurance that all of the controls are still in place, and maybe that's also for Mark?
Yeah, hi, Andrew. So yes, indeed, Mark is on the line as well and can comment. But we are still, we still have our task and finish group overseeing this work, because work does continue. And I think some of the closed wards sort of during the COVID period have provided opportunities to continue that work. So as the report says, you know, and indeed, you know, our last case now was in January of this year. And there have been no further cases, but I'll let Mark add a bit more. But I think it's just to reassure the board that the work and working with our authorised engineers still continues to address those issues at Ealing Hospital.
I think the only thing I'd add, just echoing Fiona's comments, is that I think we're spending £480,000 this year on additional work at Ealing to further improve the situation. It is a long process, and it is a collaborative process between clinical practices, engineering, and cleaning. But I think I'd take some assurance in the fact that there's been one case in the last 18 months on a fairly unusual set of circumstances, rather than any form of widespread concern.
Thank you.
Thank you. Well, let me come on to Vanetta.
Hi, Fiona. So this is just on the last part, your top priorities for 2021. And the post-COVID-19 pandemic. So I was just hoping that we would see in due course a little bit more detailed plan around COVID surveillance in inpatient settings.
Yes, I think just earlier to comment about the report. Remember, this report finished on the 31st of March. So I think, to be honest, that you're going to see greater detail in the annual report next year, because COVID was only just beginning for this hospital in the beginning of March. So I've just made reference to it. There are no more details in this particular year's report.
That's fine, as long as we can at another board subcommittee just see a more detailed COVID and respiratory illness surveillance plan for the trust. That would be very useful.
Yes, and I think obviously there's obviously the recovery board and everything else that goes with it at the moment. So a lot of our work that we're doing at the moment with the infection control team is actually supporting services get back to as normal as they can be, you know, taking on board national guidance. So that's what my reference was in the priorities of what we're doing at the moment.
Very good. Thank you very much indeed. In that case, Fiona, and well done on all your work once again. Let me move on to the operational performance report and the Chief Operating Officer.
Thank you, Chair. So this report and elements of it have been discussed at length through Trust Executive and the Finance and Performance Committee, and also is subject to a significant amount of discussion through the twice weekly COVID recovery group as chaired by Simon Crawford. So this report just lays out our performance in the month of June for all of the constitutional standards for emergency care, cancer diagnostics, and obviously referral to treatment. I'll draw out, I think, 3 key points from the report, if I may, Chair. The first one, and I thank you to the Chief Executive for calling out in his report at the start of the meeting around our emergency care performance for the month of June. So we declared 96% compliance against the 4-hour standard, which is 95%. So I just wanted to publicly acknowledge all of the work of our staff to improve flow through emergency care in the wider hospital. I think that is a significant achievement in view of some of the pressures which we are all aware of through the months of March, April and May. And then if I may, Chair, I just wanted to draw out obviously the concerning position of patients waiting across cancer diagnostics and referral to treatment. And I think as this is a public board, to call out the number of 52-week waiters that we've experienced so far, which, as colleagues will be aware, is in line with a number of other trusts, but we have declared 426 patients who have already waited over 52 weeks. So I just wanted to acknowledge that publicly. That is a concern to the organisation, and I'm sure a worry to patients who are waiting for treatment. So just to reassure the board and public that we are now very much focused on recovery and trying to bring all of our patients forward for dates for surgery as quickly as possible. And as colleagues will be aware, that's covered off at length every day of the Trust Recovery Plan. And then just my last point, if I may, Chair, I think it's really important also just to draw out to colleagues that in the performance report itself, which is page 158 of the 280 pack, there is an appendix which looks at by subspecialty all of the patients by total and how many patients have waited over 18 weeks or 6 weeks. And I think, although that's just a numerical number, that really does draw out the scale of the challenge of having suspended the majority of our elective work over the last 3 or 4 months. So I just think it's important to call that out. It's a standard part of the report. That obviously is the focus of our recovery plan, is to get those patients back in for treatment where appropriate. Happy to take questions at this point, Chair, if I may.
Sure. Any questions? Well, I'll ask you one in that case, and then I think is that you, Vanetta, who's got your hand up? Yes. Okay, I'll be with you in a moment. I suppose my question is this: is there anything holding recovery back at this point?
So I think thank you, Chair. So I think, as the Chief Executive said, I think the sophistication required to deliver the recovery around the infection control has been complicated to deliver, but I'm delighted with the work of Lisa Knight and colleagues that we are now very much having agreed the sites by status that no longer is the main issue. So we are able to start recovering on that basis. The other challenge has been availability of staff, those staff returning from either shielding or sickness, and that now is an improved position. And our last main challenge around theatre recovery has been our long-standing issue around our anaesthetist establishment. But again, there are plans in place to address that. But that has been a challenge for us in terms of being able to provide sufficient workforce both across our NHS capacity as it restarts, as well as servicing all of the private sector work as well. So our baseline is perhaps lower than others in terms of our establishment. But again, we're very aware of that, Chair, and we're working actively with our anaesthetist colleagues to address that.
Thank you. Anita.
Alice, I am looking at the appendix that you referred us to, Appendix A. And looking at that and walking back at the data from cancer treatments to diagnostic rates to referral to treatment, can you tell us what are the specific bottlenecks, especially for cancer treatment, that you are trying to address immediately, especially for the 400 odd patients that you talked about earlier?
So two parts of that to make sure that we return our diagnostic capacity to pre-COVID levels where appropriate. And you'll see in the report, Vanessa, and as discussed at Finance and Performance Committee, that's a combination of using the private sector for diagnostics as well as resuming services here. So the CT MRI backlog is clearly an important part of that. And then from a surgical point of view, you'll be aware that we've now restarted Northwick Park elective operating, and we have focused on some of our more complex patients first, as well as continuing to use the private sector. So our efforts in terms of the daily COVID recovery is making sure there's daily tracking of throughput through diagnostics and in turn surgery as well. So we're prioritising those clinically urgent and cancer patients. And I'm pleased to say that there has been an incremental improvement in the cancer performance, particularly for our 62-day position, which you as a board will not have seen, but the preliminary position for June going into July is starting to see some incremental improvement to that. So we are starting to treat more patients against those original standards better.
So based on that, sorry, Alice, to just pursue this bit more. So based on that, I'm looking specifically at head and neck, where our performance is at 50%. And urology, again, 42%, 43. So based on this prioritization that we are doing in diagnostics and theatre time, by when would we see this performance coming up to pre-COVID levels?
So our expectation would be that we would start through Q3 and Q4 to see those return to more acceptable levels of performance. I wouldn't want to give you a specific timelines, Vanessa, at this stage, because I think it's appropriate to do so, because we are still working through our post-COVID procedures. What I can assure the board is that we have now started and we are learning as we go through. But there is clearly an expectation from London and from Chris and the executive team that we would look to return to more normal levels of performance through Q3 and Q4 of this year.
Okay. I'm sure that subject will come up later on in the board as well. Did I hear somebody just wanted to ask a question?
Chris.
Chris, come on.
Yeah, well, just also worth reminding ourselves, of course, is that the productivity that we were used to, the targets that we had on productivity, such as theatre throughput being a key one, of course, has changed, because with the donning and doffing, the more thorough cleaning, etc., that goes around the pathway, then the numbers of patients that we're seeing per theatre session has changed to what the pre-COVID situation would be like across the NHS. So we mustn't forget that we'll have to readjust our sort of optics on what is acceptable productivity compared to what it was like prior to the pandemic.
Very good. Yes. Were you going to add anything there? Did I, Ellis? Were you going to say something else there?
No, that's fine. Thank you, Chair.
David Moss had his hand up. It's just gone down. I don't know if David wanted to comment.
No, I'll save my comments for later. Thank you.
Thank you very much. Any other questions then? If not, thank you very much. We'll move on to the Finance and Performance Report.
And Chair, I should have said that Jonathan Reed gave his apologies at the outset of the meeting. As you, from our earlier call, he's not available at the moment. And Caroline Trevena is covering for him and is on the call.
Very good. Caroline, do you want to take us through?
Yes, I will. Thanks, Chair. Just this report, as highlighted on a number of reports, has been through Finance and Performance Committee. I'll just pick up on a few highlights, if I may, and then happy to take any questions. So we continue to report break-even, which is highlighted in the Chief Exec's report. That's in line with the national funding situation during COVID. But as a trust, we are actually spending less than our non-COVID plan. So month on month, we've been spending less than the expectation through the top up, but we are spending more on COVID, and we're expecting to see that shift as the months go on, where we move more into recovery, and it's part of our underlying position. So as I said, we reported break even in the month. Our expenditure on COVID was slightly higher than in previous months at 4.1 million. That was mainly because there's a little bit of a catch up on PPE, and also we've been doing a little bit more testing. Overall, our pay position is coming down, and that's mainly around temporary staff, in particular agency and bank. And we're seeing where staff are being redeployed from our permanent wards that are closed, they're being used in other areas, so our requirement for bank and agency staff is down. I'll just draw quick attention to the technical adjustment we've made on PDC. The guidance changed in months, so we've had to reflect that in the year-to-date position. Due to the funding arrangements with our block contracts, our cash position is perhaps higher than anybody would have seen within the trust, and that's because we're receiving all our payments in advance. And our capital programme is being managed tightly. As you know, we've got an agreed budget of just around 46 million, and managing that through the capital review group. The main risk around capital is we've got 22.7 million of unfunded projects, some of which are, have been started at risk, but we're comfortable that slippage and the contingency within the capital programme will cover any risk arising from that. So, it's unusual for a trust at the end of Q1 to be in such a such a position that we're reporting break even, and I'm sure the board have not seen that before, but it's just due to the uniqueness of the financial regime as we currently stand. So happy to take any questions.
Thank you very much. Well explained. Well done. Any questions? No, I thought I can understand that in some ways. No. So well done. Thank you very much for subbing in there. And I'm glad to be able to give you a relatively painless run through. Thank you very much. Thanks for coming and talking to us. Thank you so much.
No problem. Thank you.
Thank you. Very good. Thank you. WRES action plan.
Oh, thank you, Chair. So I'm finding it quite hard to follow in Yvonne's footsteps, but I will try, and I'm obviously taking on board a range of points she raises, and we'll build those into our next RES action plan, which we're currently analysing the data. And one of the issues that was highlighted by Yvonne was our disciplinaries. I mean, I'm hoping this year, due to some of the process changes we made in relation to the triaging of disciplinaries, that we will see an improved performance there. So I'm fairly optimistic in terms of that indicator, but we've clearly got and will continue to have work. I mean, Chris has already mentioned the listening events that we continue to hold monthly with himself, Lisa and Martin in attendance. And also we've been very pleased that Janet and Vanessa have also joined those events and contributed, which I think sends a really positive message to staff as well. In addition to that, Chris and I meet the network bi-weekly, which is growing in size, and we're looking at how we can support them with their agenda and also delivering against the North West London plan. We've also, on Yvonne's recommendation, we've engaged a consultant to work with the BME network to help them grow and become more proactive in terms of being able to deliver against their agenda and provide advice and support for them. So she starts next week and will work with the network the next couple of months. Also, Professor Kevin Fenton spoke to the BME network last night. And he's the Regional Director of Public Health for London, and also commissioned a recent report on BME deaths in relation to COVID. As you know, we've been undertaking risk assessments for our vulnerable staff.
and the challenge was to risk assess all BME staff by last Friday and all staff by this Friday. We have got a focused approach to that. As of today, 79% of our BME staff have been risk assessed, which we're not quite there, but we're hoping to. You know, we do have to bear in mind we've got 5,500 BME staff. That's quite significant progress over a month, and 69% of all staff have been risk assessed. But I can provide some assurance to the board that it is a priority and we're working hard. The report also outlines our BME leadership programme. Last year we had about 16 people on our BME leadership programme. This year we've been overwhelmed by applications, and hopefully that's a reflection of some of the work we've been doing recently. We've got over 40 applicants. So rather than turn people away, we've decided to run 2 cohorts simultaneously, which I think is a positive step. The board mentoring, as you're aware, we've assigned you all mentees, and I'll be writing to you. It's in my inbox to tell you who your mentee is. They're currently being trained to undertake the reverse mentoring, but you're welcome to start the mentoring process as soon as possible. The associate NEDs, I know Amias and David have been in conversations with NHSI. The execs have all volunteered to become a diversity champion. There's just one protected character, and I need to have a conversation with one of our execs about taking up that mantle. We've started and we've got very positive conversations going with, actually, she's a black resident of Brent who also has a huge experience in the area of inclusion and diversity. And she was starting a conversation about her becoming an advisor to the board and potentially a NED as well, which would be a positive step. And Janet is going to work with me on how to develop that remit further. And we've got a conversation next week about that. She's also helping me develop the independent advisory group, both internally and externally, which hopefully links into some of what Yvonne was saying and Drew had brought about, you know, some of the inequalities in the community as well. So I'm hoping that will be a positive. And more, it's not included in the report, but I'm also working with an organisation who supported us before April strategy in relation to rolling out the heart values and looking at the health and well-being of our staff and how they feel following COVID. And so we're doing some initial work around that, which will be launched in a couple of weeks. It will be a questionnaire initially, but we can pick up on some of those issues, and Yvonne mentioned, together with able to identify potential pockets. We're then looking about setting up a range of conversations with staff about building better relationships around culture and values and respect as well, which I think links very well into this agenda and also supports some of the things that Yvonne was saying. So I'll pause there, and I'm happy to take any questions.
Thank you very much. I know Janet's got her hand up.
Yeah, Claire, thank you. It's a really good action plan. Just going back to the risk assessment for BME staff, my understanding was we had to reach 100% on this, and I appreciate it's a big exercise, but when do you think we will be able to reach that figure? So that's my first question. And my second question really would have been to Yvonne, which is I'd appreciate her views on, given that it takes time to build pipelines for people to reach senior roles, but about sourcing senior candidates from outside of the NHS even say the private sector, healthcare sector, to enable us to be able to make faster progress?
Okay, well, let's start, please, with you, Claire. And then I don't know if Yvonne is still on the call. Is she?
No, she's gone. So in terms of the BME staff, I'm hoping, you know, by the end of next week, we will be there. I mean, the data cut-off is the 31st, and I don't think we're going to be at 100%, unfortunately. I know Ellis is working very hard with the divisions to encourage them, and I'm certainly seeing lots of email traffic around it, and there's tremendous efforts. So I can't give you the assurance that we'll get to 100% by the end of the month, but I'm hoping shortly thereafter.
Thank you.
In terms of the diversity in senior positions, one of the people that we've been working with, who is also going to be undertaking a review of all of our recruitment processes, etc. She also has a headhunter organisation which looks at diversifying senior leadership roles. So we're looking to get her advice and support. I've also commissioned someone called Simon Fanshawe, who runs an organisation called Diversity by Design, because you know that our traditional way of recruiting, our traditional job descriptions, that it doesn't really expand the diversity of our senior leadership. So we've decided to pilot it in one role, first of all, because it does require a lot of different type of approach. So we're going to trial it on one role, and then we'll see how that goes and if we might expand it further after that.
Thanks, Claire. Perhaps you could ask that question of Yvonne when you're next in contact with her.
Yes.
Thank you.
Have we, David, have we got any other hands?
You've got Andrew, and you've got Drew, and you've got Vanessa.
Okay, let me start with you, Drew, and then I'll come to you, Vanessa.
I've got two questions. One for you, Claire, which is really interesting to see the executive diversity champions. When are you going to inform the board and the wider organisation who and what portfolio they're taking?
Imminently. I just need to sort out the one protected characteristic which we haven't assigned yet, and then it's going to go out publicly.
And I also wonder whether there's any value in kind of buddying that with non-exec directors on the board.
Yeah, that's a really good suggestion, Drew.
So I quite, yeah. I suppose, and then I want to just turn to the risk assessments for staff, and this is a question for Ellis. Ellis, I assume that this is being delivered through line management. What do you think is preventing the progress of that?
So it's an agenda item on my operational management group this evening, Drew. So I'm going to go round to each of the divisions and get detail as to what's preventing them from completing it by division this evening. So I'll be able to answer that question very directly after 4:30 today. And to answer your first question, yes, it is being driven directly through line management, and I have spoken already to 2 divisional general managers to make sure that this is their priority for the remainder of this working month. I'm happy to respond to your second question after OMG this afternoon.
Thank you.
And Andrew, I've written to all of the divisional general managers just this morning, asking them, is there anything more that we can do to support them or in achieving 100%?
So just I know this, just to jump in, sorry, but we are never going to hit 100%. We've still got lots of staff overseas who are stranded. So I do think we ought to. There is just no way we can do an assessment for somebody who's still stuck in the Philippines.
So absolutely, Lisa. So anyone we're informed of, we know about, either on paternity leave, off long-term sick, etc., they come off our denominator.
Okay, good. So that's, I mean, I think there is an element of data management in our compliance as well. This is an enormous tranche of data that has been put together over a period of a month, and I'm struggling with exactly the same thing for fit testing data, and it does take a while to sort itself out. Certainly when I am talking to my staff, they are saying that person has been done, and therefore they could come off. So I think there are a lot of staff who have been done, and the divisions have tried really hard to do this. It's not perfect, but I still think there will be better compliance once the data catches up with itself as well.
Okay. Vanita, let me bring you in with a question.
Thank you. Just one comment and then one question. So, I did hear a lot of conversation around the fact that, because to bring in diversity in senior position, we should also, given the time sensitivity, and correctly so, look externally. Can I just urge us to maintain a good balance between external and internal, because in senior positions. And before we look internally, I urge you to look before we look externally. The question, the assurance I'm seeking is that once we have done, and it's around risk assessment, that we have a good number, a high number done already, and we are, targeting. The question being brought to us as a board on implications on our staff and the trust in terms of business as usual of COVID second wave.
That didn't come over that clearly, if you don't mind me saying, Vanessa. Sorry, you're having intermittent signal. So just try and articulate that question again, if you wouldn't mind.
I would. So is this because I've turned my camera off? Can you hear me now?
Yes.
Okay. So, but I assume my first question has come, the first point has come through, which is around looking internally for diversity. The second thing I was making was risk assessment. Now that we are heading towards high 90s in numbers, when will we see implications for this trust and the staff?
So, in terms
we presented at the board with pandemic second wave.
So, in terms of looking internally, absolutely, and that we had conversations with Ellis earlier this week in relation to that exact point. I'm hoping that by September, I will have got, or at least the end of September, have a talent management strategy and plan for the trust to identify our talent and help us manage and develop that internally. In relation to the second point, I can give you the board data on how many of our risk assessments have been referred to occupational health and how many people have been redeployed as a result of those risk assessments or where adjustments have been made. So I can provide that data for you in more detail.
Claire, I think what I'm asking is that, yes, that will definitely be useful. What I'm asking is one step further. What I'm asking is one step further, which I'm asking is, so what will be the implication on a workforce planning?
Well, obviously, in terms of those people who may not be able to work in our red areas, that has implications. But at the moment, with the mitigation that is in place, there's only been a small number of staff who've been redeployed and cannot work in those high-risk areas. So the implications, as I saw the data last week, were not significant because of the mitigation that had been taken.
Okay, very good. Thank you very much for that. Any other questions? No?
No.
Okay, thank you very much indeed. That's very clear. Thank you very much. That takes us on to learning from patient's death report. And that's you, Martin, I think.
Hi.
Hello, Martin. Yeah.
Okay, so the report is obviously here. I think it's worth stressing that this is primarily not the report for the COVID period. And so we need to, that obviously needs to be sort of taken into account. What we have done is try to discuss how we're adapting with the new medical examiner system. So that was due to start 1st of April, and we've had to sort of implement it on the fly in the period sort of leading up to the COVID procedure, and discuss some of how that will affect the learning from deaths reports going forward. In terms of where we are in terms of mortality, I'm happy to confirm that our figures are relatively good, and that on the most recent year to date, we remain the 9th lowest SHMI, so summary level hospital mortality indicator in the country, and that's to the that was to the period up to February, I think, 2020. But happy to take COVID will adversely affect mortality indicators. In general, what the approach they're trying to adopt is to strip it out of the SHMI as far as is possible, because it's not designed for a sort of pandemic, and so that all the numbers will be heavily skewed by it. So we'll have to see what the impact of that is. Obviously, we're expecting in-month mortalities will jump very high for that period, obviously, and mortalities related to respiratory complications and so on. So exactly how the figures look and can be interpreted, we will have to look at. The other thing is probably worth flagging that we will bring back in some detail, probably whenever it's scheduled, but certainly to Quality Committee and then here, is the mortality around intensive care during COVID. And just to flag that our mortality on the ICNARC data will look high, because a lot of our patients, well, for various reasons that we can go into, but one reason is obviously that we transferred out some of our patients with a better opportunity to survive. But there are other reasons as well, such as the background demographics and so on. So I'm expecting that our mortalities on intensive care will look high, and we will report into that in some detail in due course. But certainly for this period and for the ongoing periods, we've had no mortality outliers, and our performance is excellent. The only slight irritating caveat on that is to say that Imperial are still the 2nd lowest mortality in the country, so they are slightly ahead of us.
Fair enough. Any questions?
You've got David Taub, Chair.
Yeah. Can you hear me?
Yeah.
Yeah.
Yes, we can, David.
So Martin, at the bottom of page 5 of your report, so that's 157 of the PDF, you mentioned the Dr. Foster Healthcare Intelligence Portal.
Yeah.
They usually give mortality rates for a whole series of different situations. For example, aortic aneurysm, myocardial infarction, respiratory failure. So in the year prior to COVID, do we have any specific outliers in any of those particular areas that you're concerned about or you want to draw to our attention? And I'm particularly interested, for example, in the areas that we are being looked at in terms of our specialist services, like aortic aneurysm, colorectal cancer.
I haven't looked at the Dr. Foster ones recently. As I say, I know from the SHMI does the same thing, and on the SHMI, no, we're not an outlier on any area, but we can do something. The Dr. Foster in general is less. There are two different. Just to background, there are two different mortality indicators. Dr. Foster was the first one, was the hospital mortality. In general, it's very skewed by whether you code deaths as palliative.
Sure.
And so a number of trusts, you'll tend to have a higher number on it if you code less deaths as palliative. So some trusts, for instance, UCH, code up to 30–40% of their deaths as palliative, and other trusts don't. So in general, the SHMI is preferred because it is it's not affected by palliative care coding. So in general, we've moved over to the SHMI. The real advantage Dr. Foster has over the SHMI at the moment, and the only reason we've carried on using it, is that they give us slightly more recent data. So it takes us a bit longer to get the SHMI data, because the SHMI data is based on the HES data, whereas the Dr. Foster is based on the SUS data. And on the SHMI data, we haven't got any outliers. We can go back and look at the Dr. Foster as well.
It'd be really helpful. Maybe you want to bring it to the Quality Workforce and
Sure.
Safety Committee to see some of that. I think it's relevant in terms of the analysis of the specialist services that are taking place, because it would give us some reassurance that actually we have no unsafe or worrying areas.
Sure.
Okay. Any other question? Any other hands up?
None seen.
No. Okay. Well, thank you very much indeed, Martin. Thank you.
Thank you.
Very good. So we'll move on to Infection Prevention and Control Board Assurance Framework. Thank you. That's the Chief Nurse.
Thank you, Amius. So this document has been to no, it hasn't been to Infection Control. What am I talking about? Quality and Safety Committee, and has been substantially updated since it was last there in June. So this is a newish document sent to us in May by NHS England and Improvement to help boards and organisations make sure they have the right infection control processes in place during and post pandemic. So we have discussed it once before at Quality and Safety Committee. Just to say, in the background, the CQC are using this document quite substantially, and Fiona, who you, the DIPSI, has had 2 conversations going through this document with them over the last couple of weeks. I had a call with the CQC yesterday, and this is the main thing that they are interested in. And they are expecting to provide us with a report back on our infection control BAF in the very near future. They're telling me this is an informal feedback, but it is going through a ratification process at the CQC. So I did challenge them on how informal or formal it was. So they are seeing this as being very material. I'm assuming the document is read. The items I wanted to pick up were fit testing, which we've got down as orange. We continue to fit test staff. We have got more to do, but we continue to have significant supply issues with substantive supplies of the right masks. I spent quite a lot of time with the fit testing team this week, and literally we have about 20 different supplies now, small numbers of, and so keeping anything for staff to use on an ongoing basis continues to be an issue. The good news is we have had some small respirators arrive this week, and so we are fit testing a lot of staff who were unable to get small masks, so we're in the process of doing that. The other thing we did flag up was lack of audit associated with the items in the BAF, and we have now started some audit processes primarily around hand hygiene and PPE compliance. We started that at the beginning of July, so we shall have some data soon. And then just again on PPE, really, the reason we're auditing that is we have got some non-compliance. So we still have individual members of staff not wearing the masks in the organisation, although that is significantly better, I have to say. And we did have an incident in A&E where they stepped down their FFP3 masks for patients with aerosol generating procedures in the non-COVID part of A&E, and that was not our guidance. Our guidance was you must, if you are doing an AGP, use full PPE for that. And so there have been a few little hot spots where they've not been compliant with the guidance, and that's why that is on as orange as well. Just happy to take questions.
David Moss, Chair.
David Moss got his hand up.
Thank you. Lisa, just quickly, you mentioned that there were some members of the staff that were caught not wearing masks. What action do we take when folks aren't complying with the rules?
So at the moment, what we don't seem to have is regular non-compliance. So I'm out every day challenging people about their masks, and without exception now, they are just saying, oh my God, I forgot, I'm so sorry. You know, it's that sort of thing. There were a few members of staff at the beginning who I caught 3 days in a row who refused to put their masks on at the front door, and they had individual conversations with them, and they are compliant now. What I haven't had is anybody who has been raised as being continuously non-compliant yet. If that comes, but I mean, we have an infection control policy. Our policy is very clear. If you are continuously non-compliant, we have a process, and we wouldn't hesitate to bring that in.
Thank you.
Chair, I've got a very small point for Lisa. This is a dynamic document. I think it would be helpful, given that it's being used by the CQC, if it was dated a bit like a balance sheet. This is the view at a particular point in time.
Yes, thank you. We will do that.
Very good. Any other hands up? I don't see any. No. Okay, thank you very much. Thank you very much for that. So that brings us on to the summary report from board committees, starting with finance and performance. Needing to unmute the microphone as well, probably.
That better?
Yes, much better.
Well, we had our last meeting on the 22nd. The principal areas of discussion were on the quality and performance report that we had this morning, and also on the finance and performance meeting. There were no new additional risks raised, and I don't think that there are any substantive points beyond that to raise, other than we did, in discussion of the brief discussion of the finance papers, register that we will need to start having a look at the underlying efficiency of the organisation, how that's measured and how that's positioned in respect of where we need to go, where we'll need to be in the future when the current exceptional circumstances play out. But we just started that conversation. It wasn't substantive. I think those are the main points from memory.
Thank you. Thank you very much. Let me come to the audit committee in that case.
Thank you, Chair. We had our last meeting on the 16th of this month. A few things to report. We received the revised internal audit plan. Obviously, the internal has been severely disrupted this year, and that quite a number of the audits are now due to take place in the remainder of this year. Whilst the internal audit team assured us that they had capacity, I think we still need to be keep our eye on whether or not our staff have capacity to be able to participate in these audits, and we look forward to receiving kind of progress from them. We received slides from the National Counter Fraud Authority were shared with us from our local counter fraud service, and obviously there's a whole heightened awareness of fraud that could be committed during this period and over the last few months. One area that the audit committee explores in a little bit more detail was potential fraud over data manipulation. Mm-hmm. And particularly in reference to kind of waiting times. We have asked for assurance from the Finance and Performance Committee that the data quality on the waiting lists is good, and we look forward to receiving that. But we then also talked about where does responsibility lie and accountability lie for the delivery of the constitutional requirements around offering alternative provision for people who have gone past the waiting time points. Jonathan took that away to produce a note, and he has shared a draft with me and with David and Neville, and he's going to distribute that separately to the board following this meeting. And in that note, it's clear that the accountability still lies with us as the trust, but working with the ICS and other partners, that we are discharging our responsibilities of trying to find alternatives if that is possible. But I think this is going to be an issue that we have to keep our eye on going forward, because we still maintain that accountability when people go over the waiting times that are defined in that constitutional standard. I think the other issue is that we noted that we haven't seen a full trust risk register for some time, and that we look forward to seeing that at our next meeting. And obviously that trust risk paper is really to be held by the Quality and Safety Committee, but it comes to the Audit Committee for information. So we look forward to seeing that. I'll deal with the BAF feedback when we get to that item on the agenda.
Thank you very much. Thank you. Quality, Safety and Workforce Committee.
Right, we had our last meeting on the 20th of July. And most of the reports that we looked at are actually on this board agenda, like the annual safeguarding report, the annual infection prevention and control report. The nursing workforce report will be coming to, learning from patients' deaths. We did spend quite a bit of time just picking up what Drew said on the recovery risk register. Also the workforce report, which Claire will cover shortly, we looked at as well. The only thing that, if you like, isn't at the board for this month is the annual report from the Guardian of Safe Working, which I assume, Martin, will that be coming to the next board, please?
Sure.
Yeah, yeah, yeah. So, I mean, those really, Ellis assured us that he was on the case regarding statutory and mandatory training, because there's an opportunity now to get up to speed with that and ensure that we meet the 85% targets going forward. There's a particular issue, as we know, with the medical and dental workforce on that. But Ellis is on the case. Thank you.
Good. Well, if Ellis is on the case, we can all relax. No doubt.
Chair.
Sorry, we've got to be allowed to smile at some point during this. Very good, very good. Okay, well, I thought that was all very clear. And I don't know if anyone who's not participating in those committees wants to ask a question or for any of those summary reports. I thought they were all excellent. No one? Okay, well, then we'll move on to the board assurance framework. And this is a chance for David Searle, as Director of Corporate Affairs, to speak to us.
I'll just say a few words. Thank you, Chair. As Drew has indicated, this report has been to the Audit Committee, and the Audit Committee do have some comments and made some observations in respect of the report. Of the risks that we have, 13 of them, 2 were updated. Ellis has already explained earlier in his report on operational performance the risk in respect of constitutional standards. That is reflected in this updated board assurance framework, with a change in the level of risk. And similarly, there has been additions to the risk associated with COVID-19. And again, there's been some additional language added to that risk to reflect the second wave and the planning that we are putting in place for that, and that's with the Director of Strategy. I mean, I think the observation from the Audit Committee, and indeed I think from executives generally, is that there is a lot of change which is in the wings, and the Chief Exec previously has talked about the new delivery programme and the trust objectives and focus that we have, and it is probably right that we take a look again at the strategic risks in respect of this organisation. Thank you, Chair.
Thank you. Any questions?
So, Chair, from the Audit Committee, and David kind of is right in what we felt. I think that because we weren't able to see the trust risk register, we weren't able to undertake a deep dive on the new BAF risk that speaks to COVID, and we weren't really able to. And with regards to the BAF itself, we weren't really able to provide assurance to the board on movements of risk at this stage. and also we also received the recovery risk paper as well, and further work was needed on that, which was done in time for the Quality, Safety and Workforce Committee. I think on the BAF, we did have a discussion about whether or not the BAF, this paper in its current form, should come to this board meeting. I think we felt that given where we are now, and given what has changed and actually what the future strategy is emerging for us and for the ICS, that the BAF really is no longer fit for purpose, and that we need to go back to it, revise it in light of where we are and what our strategy is going forward. Until we do that, actually the BAF paper doesn't really give us the assurance that we need. And so we felt that it should come here, but also it should come with a note. And that note was being put into the cover paper by David to say that actually the work is going to take place over the next couple of months to be able to reflect what our new strategic risks are, and therefore what are the controls and the mitigations and the gaps in our assurance around those.
You want to add something, David, to that?
No, I think that's entirely appropriate.
Simon, let me bring Simon Crawford in. You have to unmute yourself, Simon.
I should know by now, shouldn't I? Apologies. I would absolutely agree and endorse with that it does need to be reviewed. Not least because if you think about it in terms of how we developed the BAF last year, it was having agreed our objectives and therefore what were the risks to delivering against the objectives. We have changed our objectives this year. The goals are similar, but the objectives have changed. So I think it does need to be reviewed in light of those objectives, in light of the how we work as part of the ICS and the risk that we still see in the context of COVID. So absolutely agree. It's not a 5-minute job, but it absolutely is something we need to do.
Okay.
Agree. Yeah, absolutely agree.
So everybody's in the same.
Yeah.
Everyone's in the same place on this. That's good.
Yes, I think we do need to remember that the BAF needs to be a live and dynamic document.
Yeah. Yes,
not to stick to where we are rather than where we were.
No, it does. It does. And things are changing very fast. And we're not.
We have.
Yes. Okay. Very good. I'm sorry. I saw somebody's hand up there.
Vanessa.
Vanessa. Okay. Do come in.
So I do agree with all the conversation earlier around needing to revise the BAF. My point is that, specifically around our most important and the highest risk on BAF, which is 1038, do we feel that we have appropriate controls in place? We seem to have listed only 2.
Right, don't all fall over yourself in answering that question.
This is a risk. This is 103. This is the failure to deliver the constitutional standards. Perhaps this may be better placed than me in terms of the controls.
Sorry, but is there a particular question about the controls that you wanted to ask? I wasn't quite following the question. I apologise. Okay.
The question is, do we feel, given the how high the risk is, and given the the risk description that it's actually affecting all our constitutional standards, do we feel that the controls that we show in place are doing it justice?
My professional view, yes, Vanessa, but I'm happy to take questions or queries in terms of how we might be able to improve the wording of it. But I'm confident that that reflects the actions that we're taking at this moment in time.
So I think the 4th column, where it talks about positive assurance, is better articulates the mitigations that we've got in place than perhaps what the 3rd column headed controls in place. There probably is some tidying up about the wording and the structure of it, but I'd agree with Alice. We have got the controls in place. Whether we've articulated them in the right column, that's something as part of the review we can tidy up.
So does that answer your question, Vanessa? Is there a particular comment that you wanted to raise back through the board so we can tidy this up in a more satisfactory way for you?
Yeah, so I would expect a little bit more details around what controls are we putting in place for demand and management and schemes, and also for outpatient and theatres, because and then we've talked about demand management scheme. So we've gone one broad and then one quite narrow. I'm
And
sure you're doing a lot more than this.
Yeah, and I suppose that's my point. In the column that's headed controls in place, it is quite like, but if you look at the next, not the red one, the next one, you know, quite a lot of the capacity stuff is done in Recovery Gold. We got the weekly breach meetings for an A&E. We got the weekly PTL meetings in terms of people waiting. We got the planned care and cancer boards looking at the critical ones. It's just we haven't articulated perhaps in the right way, and we need to have a look at it.
Okay, fine. We'll see, and no doubt we can follow up and see how it's formulated next time. Okay. Any other questions?
Sorry, Amos, before we move on, could I just ask that I think if we're not feeling as though that domain of the BAF is well described or the controls are as extensive as we'd like them to be, I think this is a matter for the Finance and Performance Committee to look at.
Yes.
And I'd like the Finance and Performance Committee to provide assurance to the Audit Committee that they are content with how that is being done. Because I just think that we've got to get into the practice that all subcommittees own those areas of the BAF which speak most to their domain, and then all of the audit committees to assure the board that that is in place.
Okay.
Chair, could I just also add, I think we do need to strike a fairly careful balance between a lot of words in the board assurance framework document, which then makes it a bit impenetrable for the board to pick up on the key points. And clearly some of the heavy lifting can be done in the committees, but I would just try to encourage focus. We have actually got in some of these strategic risks some quite lengthy narrative assurances and controls, and I wonder if it's too lengthy whether we actually lose sight of the key points.
Okay, what I'm hearing isn't that it's just about asking for more length. It's a perception that it's not targeted on the right risks in the most effective way, is what I am hearing. So it's a more serious concern than simply styling of a document. And I know you don't mean it like that, David, but this is, you know, we need to see a revised board assurance framework that's focused on what we see as our risks today, and we need to be sure that the controls in place on it actually satisfy us that they answer the requirement, and we just need to see all that drawn together. It's not, we all agree it needs to be done, so there's nothing difficult about this, but I just think we can't really be comfortable until we see that. So that is a point forward, quite a substantial point forward, isn't it?
Indeed.
Okay, I think we'll move on from there. Thank you very much. So I'm going to move us on to incident report with the Chief Nurse.
Hi, thank you. So the incident report, which has been to Quality and Safety Committee, the headlines I really wanted to note were that we did have a significant downturn in reporting of incidents during the major pandemic phase, despite all efforts to try and improve that. That is now starting to improve slowly, and obviously when we update for the next month's report, we'll be able to see if that has improved, but anecdotally I'm being told it is. And just to assure the board that during the pandemic, we did continue to run a lot of our governance processes, not necessarily in the same way. We do run a weekly serious incident review group, which we didn't run during COVID. We ran a mini SIRG, which concentrated on very much the declaring of incidents and the review of the reports, rather than the learning, which we have sometimes 10 or 15 people around the table for. But we did continue to obviously declare, manage and monitor all of our reports. Sorry, I don't have any water either. Thank you. So that continued. The one thing I did want to flag to the board was that we had a Never event in April, which was a retained guide wire, and Martin is going to update on that because he was dealing with the individual clinician on that incident.
Sorry, before we come to Martin, I just want, do have a sip of whatever that is, that bottle you've got there. Do have a sip of it, please. And then I do want to come back a little bit to be really clear from what you're saying. So there was obviously a period of time during COVID where you weren't doing lessons learned. You were simply noting and managing incidents. When did you switch back to doing lessons learned again now, have you? Is that what you're telling us?
Yes. So
if so, when did you do that, please?
Yes. So ordinarily, what we do is we have a meeting on a Tuesday morning called SIRG, Serious Incident Review Group, and we invite whoever's been involved in the incident to present their reports. And we have all of our governance teams around the table, and we discuss the reports in detail. We suggest comments. We tease out the lessons learned, that sort of thing. During COVID, we had mini SIRG, where not everybody was involved, but the deputy medical director, the deputy chief nurses, the governance team looked at all the reports, declared whether they were SIs, etc., etc. We have been back doing full SIRG since the beginning of July.
Okay, good. Thank you. And are you? And it's not necessary to do a retrospective examination. You must have. Well, you're obviously considering it. I did that.
Well, so stuff is still coming through. So SIRG does two things. SIRG looks at what's happened in the week and decides, is this an SI or not? And then we decide whether to submit it. We review all the root cause analysis. So that has always continued. What is probably missing is actually the discussion part around learning. The reports themselves do still contain that, but the wider sort of richness of discussing it in a learning forum, that was what was lost. I don't think from an assurance perspective it is mission critical, but it obviously has we lost our richness during that period. Does that make sense?
Yes, of course it does. Thank you. You're explaining it very clearly. But what I was pointing towards is just this. If during that period you had extraordinary conditions because of COVID, and we're thinking about planning for the potential of a COVID crisis, and you've got evidence that you haven't really discussed as fully as you might have done, I'm wondering if it's worthwhile doing some short review process of those that you had only mini SIRGs for during that period, just to make sure there isn't something you've missed that you might want to take forward into future planning for COVID. I'm sorry, I'm being very laborious saying this.
No, I get you. Yes, we can certainly do that. I will ask the governance team to see if there's anything missing and what we could have learned. Absolutely, I get you now.
Thank
you.
Yeah,
no problem.
Sorry, Martin, for making you wait so long to tell us about the wireless.
Yeah. So this isn't the full. It's not the full report. It's just it was just to give an update because obviously it's because we've had similar issues in the past. It was something we were very concerned with. So it's just to say we did sort of do a sort of immediate review to see what had happened. It was actually a patient. It was actually one of our first patients with COVID. And so it was very, very abnormal situation where essentially the doctor went into the room without the nurse that would normally be present because at that point we were trying to minimise exposure. We didn't really have our processes and people were very uncomfortable. So to minimise the risk to staff, the doctor went into the room on their own, and so the normal checking processes weren't undertaken. So we have taken immediate steps and reminded that doctor that they're not to conduct any procedures without checking and so on, but I don't think there's any possibility of recurrence. It was sort of unique, and it's also worth saying that he did save the patient's life as well. So I think the full report will be undertaken, but I don't think that there was lessons from that particular incident that had ramifications for other sort of similar incidents.
Thank you. Any questions for Martin on that, or are we fine?
David Moss and David Taub.
Thank you. This is probably more for Lisa. Thank you. Lisa, during the peak of the pandemic, are you and the team confident that we still captured any SIs, or were there any outstanding, do you think?
So I think there will have been outstanding things because reporting went so low. And one of the areas that I was concerned about was ITU. So I went to ITU and I said, guys, have you reported everything that you should have done during this? And they said no, and they couldn't capture it. So there is undoubtedly gaps in reporting during this period. And you know, even if you think about recovery, you know, they didn't have notes or papers or anything, or you know, so even the availability to report in an infection control environment that was as heaving with viral load as our recovery area, which was ITU at the time, there were restrictions, you know, very physical restrictions as well to reporting.
Yeah. So Lisa, can I just check, is that serious incidents or just incidents? Serious ones that would be.
Well, so it could be both.
Yeah. Okay. And is there any opportunity therefore to do a bit of a sweep up and almost an amnesty to say, look, we know you didn't report it then, but at least we can capture any learning?
Yeah, we could do that. Certainly we could ask. Yeah. Yeah. I think the area that is most likely to be affected is critical care.
Okay.
Because they were under the most pressure. I think the rest of the hospital was okay, but that's the only area I'm concerned about. Unless, Martin, you would have a different view. I don't know.
We can certainly ask. Equally, I'm not sure. There are a lot of, we need to get our systems. I'm very concerned we get our systems up and running again in a sort of ongoing fashion. Whether there's a lot more that we're going to get from things that haven't been reported, I don't know.
Okay, thank you.
Okay. And it's David Taub.
Yeah, so just a quick question, Lisa, for you, and I think we probably either overlooked it or missed it at Quality Workforce and Safety. On page 4 of your report, so that's 198, yep, you give the top 5 subcategories of the COVID-19 related incidents. And I note there that, okay, number 4 was the pressure ulcer and moisture damage, obviously trust acquired. In terms of lessons learned and how we're going to deal with wave 2, if it does occur, is there anything particular you can do to mitigate these pressure ulcers, which obviously are quite nasty, particularly if they're on the face?
Yes. So it is mostly NIV related pressure ulcers, of which we have had a spike. I have been in contact with other chief nurses across London to talk to them about this, because certainly UCLH have been experiencing, as have Hillingdon, the same sort of pressure ulcers, which are from the masks on the face, from non-invasive ventilation. They happen on the bridge of the nose. But I've done this work in other organisations, and I've had the companies in, I've had new dressings designed, and so I think we are limited because nobody else is managing to sort this out. And also we've tried, well, I personally have tried to prevent this in other organisations, even by going back to how the things are designed, etc., etc. So we continue to work on it, but I don't have an answer for it, David. I'll be honest with you.
I mean, because some of these patients, when they survive, or if they survive, end up having significant plastic surgery.
Yeah.
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 So it is very nasty. But I just wonder if you okay, well, you seem to be on top of it. Whether there's a solution, obviously, is another matter.
Yeah.
Thank you.
Very well explained. Thank you very much. Okay. Any other questions?
I think Martin wants to come in, Chair.
Martin, please.
No, it's only on the NIV. So there are some specific features of COVID. So we didn't use NIV to start with, and then we introduced it in our medical HDU once the national guidelines on its use relaxed. Our impression is that it was very important in reducing the number of people who needed to be intubated. So we think, so off the top of my head, about a third of the people died, a third still needed to be intubated, and a third that would otherwise have been intubated, or at least most of them, escaped the need for intubation. And so it was very important, but it does require abnormally high pressures. And so it requires a very tight seal in order to achieve the ventilation through a face mask. And so there is a lot of pressure inevitably there, and there are other methods of giving CPAP or non-invasive ventilation with hoods. They don't give an adequate seal, and we were trying to minimise the risk of air spillage by maximising the seal. So I do think an element of pressure damage is probably unavoidable in the context of the need for high airway pressures and the inability to use the other things that do reduce pressure damage, which is a sort of shoulder harness overhead hood, but that won't give you an airtight seal and therefore would give you a greatly increased risk of disseminating COVID to other people.
Okay.
That makes sense.
Thank you. Any other? Have we got any more, David, or is that it?
No hands.
Thank you very much. Well, thank you for explaining that, and that moves us on to the nurse staffing report.
Yes, I wasn't planning to discuss this in great detail. It's really a resume of everything that went on during the COVID period with regards to the management and reallocation of nursing staff. You can see we did redeploy significant numbers of nurses, allied health professionals across the organisation. The only thing I did want to pick up was the student nurses. We did take large numbers of students who came to work for us as part of the Health Education England plan to put them into practice, and they did get paid a salary while they were with us. There has been some reporting that they have been their salaries have been removed in the national press, and what a disgrace it was. I have to say, we've been having different conversations with our universities, and those staff will be paid until the 31st of July. At that point, they will have completed all of their hours that they require to get onto the register with the NMC. And what we are doing is we are swapping out those individuals for those individuals who need to come back, who couldn't do their placement hours because either their placement hours were suspended or they couldn't do their placement hours because they were shielding or they had other issues. And so we do need those individuals to step out of practice back into the university so that we can facilitate getting through our first years, our second years, and all the third years who couldn't come into practice, and in addition our new starters for September. We have just agreed or just put forward to Health Education England for an additional 50 placements of student nurses to start in September. We wait to see if those places get filled once the A-level results are in September. And then just finally, just to note, our overseas nursing programme is not running at the moment, hasn't been running since March, and we have no plans to restart that until, I suspect, the winter time, and that is obviously completely reliant on travel restrictions. And then just finally, there are care hours per patient day figures in the back. They are not accurate. That is what we have collected, but we have so many staff still redeployed that it is very difficult for us to collect that data in an accurate way. And just questions.
Okay. Any questions?
Yes, Janet has a hand.
Yeah. Just to say, we discussed this at the QWS meeting last week, and we thought there was some really good messages in here. You know, over 400 nurses and HEAs being redeployed, and almost 4,000 staff going through different forms of retraining. And the suggestion was that this should be, and it may have already been picked up, Lisa, this should be written up both for internal and external use, because this really gives a feel of what particularly the nursing workforce did during phase 1 of COVID.
Yes. Tracy and I have had a conversation a couple of weeks, Tracy Beck, about how we can invite one of the nursing journals in and give them an opportunity to bit by bit, because they're very excited by ITU, but actually it doesn't really address the complexity of all the amazing people who, both in staying where they were, massively contributed, and for those who moved. And so Tracy and I are working that up at the moment. I think one of the things that I am getting, and I'm talking to the nursing staff a lot, is that staff who who stayed in their areas are feeling a bit hard done by, because they don't think that they are getting the same recognition as those who are in the high risk areas. And I do think this is something we need to think about, that particular contribution was just as valuable as working in ITU or in A&E or on the COVID wards, and how we get that across to our staff, because they're feeling a bit oh, we're not NHS hero type things. And that's coming out quite a lot from staff I'm talking to at the moment.
Lisa, they are heroes.
I know, but they don't feel like that.
No, I understand.
Okay. Somebody's got their hand up. Who's that?
So it was me, and the point I was making was exactly what Lisa picked up, that we need to recognise all nurses. And of course, the ones who worked in COVID frontline, but those who actually kept the ship going. That was one point I was making. The second thing is we also need to have recognition for our junior doctors, the work they have done during this time. So, you know, I look forward to something similar to celebrate our junior medical doctors also, Martin, who have actually done more than a lot more than they were ever required to or trained for.
Okay.
No, I agree. I mean, I think it was there was heroic. There's lots of heroes, and they're multidisciplinary. So we had some fantastic theatre ODAs that came, and we trained them to work the renal dialysis machines. You know, it was just so, and we had some great dentists who volunteered. Of the sort of outside volunteers, they were the best and most reliable we found were the dentists. So there's lots of people did good things. How we pull it all together, I agree. We should think about how we try and publicise and thank them all.
Very good. Thank you very much. Well, with
Sorry,
that,
so I have my hand's not working, so I have to.
Go on, please.
So no, it's just we also shouldn't forget the corporate staff, because you know, I'm talking finance staff, people working in the mortuary, the HR business partners all did the fit testing. You know, the staff testing. There was, you know, across the board, people were amazing.
Sorry, it's Chris here. Sorry, Tracy, are you on the call? Tracy Beck.
Yeah.
Yeah. Yes, she is.
Tracy, is this something we are picking up in our staff newspaper?
Yes, so for the upcoming publication of our Trust magazine, we've really tried to feed in a whole range of roles and to shine a bit of spotlight on some of those other areas outside of critical care and A&E. As Lisa's mentioned, we're working up a proposal for some features, because it is still the year of the nurse and midwife. So we'd quite like to continue to do some work on that, and again, just continuously through all of our internal communications channels. So each week in the Pulse there's a different team profiled. We're using those across social media as well, so you know, really trying to work to get some of those hidden heroes, if you like, to the forefront of some of the internal and external communications.
Thank you.
Excellent. Does that take you into workforce report, Claire?
I'm just conscious of time. This paper was considered by the QWS as well, and sort of reinforces some of the things that Lisa's been saying. Just, you know, most of all the workforce indicators are green at the moment. The fill rate for bank and agency is significantly high, and that partly reflects the fact that we redeployed a lot of staff. I know Neville asked the question about, you know, will spend, particularly in relation to agency, go up again? I think it will go up, but not by you know, anywhere near it was. You know, we've continued to be under that agency target for a number of months, even before COVID, and our vacancy rate has reduced significantly. So I'm happy to take any questions if there are any.
Are there any questions?
There are no hands.
No, good, very good. Thank you very much. No hands. No hands. Excellent. That brings us to approved minutes from board. Well, you use the trust seal. Well, it's listed there in the papers. I think we'll just note, pay notice to use the trust seal. Thank you very much for that. Approved minutes from board committees. What exactly, David, are we supposed to do with this?
It's nothing actually, Chair. This is just simply putting these into the public domain.
Right, very good. Thank you very much. Any other business? And if there is no other business, I should note that the questions for the public will be answered in writing rather than being answered now. But you're very welcome to submit those questions, and we appreciate them very much when you do bring them up. So with that, I'm going to, as I close the meeting, can I just check when the private board is starting? In half an hour, is that right?
1 o'clock.
1 o'clock. Okay. Well, with that, then I'm going to declare the meeting closed. Thank you very much for everybody who attended. Thank you very much.